Okay, I think that we can probably get started, everyone. I'm seeing a bit of a lull here in terms of the waiting room, so why not take advantage of this moment? First of all, I would really like to welcome all of you. My name is Crystal Calista Tavares. I am the Concerned Friends Board of Directors President. Concerned Friends is an organization that has over 40 years of advocacy experience for quality and long-term care. We provide education and resources to support people in navigating the long-term care system here in Ontario. We're just so thrilled to be able to kind of kick off 2023, the second month into 2023, with an educational webinar that we have made public and accessible to anyone. And we're especially thrilled to have our special guest tonight. Before we get started, I just want to say that Concerned Friends recognizes that our community work and advocacy extend to the far reaches of the traditional Indigenous territories across the province of Ontario. We acknowledge the 46 treaties and other agreements that govern this territory, inhabited by, protected, and cared for by generations of Indigenous peoples. Tonight, I'm speaking to you from just around the shores of the great waters of Lake Ontario in Dish with One Spoon territory, known today as Toronto. The lands on which I live and work hold the ancestral connections and stories of Indigenous peoples since time immemorial. And I acknowledge that these lands are the traditional territory of the Anishinaabe, including the Mississaugas of the Credit, the Haudenosaunee Confederacy, and the Huron-Wendat. I am going to just pop a very quick link into the chat and invite you to learn more about the traditional territory that you are on, living, working, playing, being alive, and so on, and to also learn more about the Truth and Reconciliation calls and how you can support them and their being actually acted on. And now I'm pleased to hand the mic over, if you will, to fellow director, Shelley Birnbaum, who is also a health lawyer, and she is going to be our moderator for this evening and to help us welcome you and Jane Meadus, our special guest.
Thanks, Crystal, and welcome everybody tonight. This is wonderful. We have 41 participants so far and more coming in, so we're thrilled to see everybody tonight. Just to give you the lay of the land for this evening is Jane's going to speak for about 40 minutes. She's going to talk to us about Bill 7, and then I'm inviting questions from all of you. You can put them in the chat. You can either put them directly to me, Shelley Birnbaum, or just put a question to everyone, and we'll use the remaining time to answer questions. We may go 5 or 8 minutes longer because I see we're very tight with an hour, and I've gotten permission from Jane to do that. We're thrilled to have Jane meet us here tonight to explain Bill 7. Jane is a staff lawyer and institutional advocate at the Advocacy Centre for the Elderly, affectionately known as ACE. ACE is a community-based legal clinic for low-income seniors and is the first legal clinic in Canada to specialize in the legal problems of seniors. Concerned Friends strongly advocated for the establishment of ACE, and we're thrilled that you're here. Jane represents seniors with legal issues related to being in an institution. It took me a while to know what institutional advocate was, Jane. It means she deals with people in an institution, such as a long-term care, such as a hospital, and she has participated in many high-profile inquests. She is an author, public speaker, and if you listen to the radio, you'll know that Jane regularly speaks with the media and advises them and gives ACE's view on the matter. Jane chairs the Elder Law Certificate Program and the Consent Capacity and Substitute Decision-Making Program for Osgood Professional Development. She is also a member of the National Long-Term Care Services Standard Committee. Maybe will tell us a little bit about service standards tonight. She is also a distinguished fellow of the Canadian Centre for Elder Law Studies. If my math is correct, you've worked at ACE for 28 years, and I can't think of anyone more perfect to help us navigate Bill 7.
Yeah.
So I turn the mic over to you, Jane. We're thrilled you're here.
Thank you. It's nice. I see I've been sort of creeping on the list there, and I see some people that I know. I just saw Lois's head pop up. So hi, Lois. It's lovely to see you. So I'm looking forward to speaking today and answering any questions if I can about this horrific piece of legislation. I would ask that everybody mute themselves though, so that because otherwise I just get distracted. My cats have started fighting outside my room, so I had to close the door. So hopefully, I don't know why they're doing that, but probably because I'm on the computer, right? Excuse me. So thanks for having me. So I am going to be talking about Bill 7, which was the More Beds, Better Care Act 2022. So let's get this working here. There we go. So I do have to tell you that anything that I provide is legal information. I can't give you legal advice, which is fact specific. And so I can't resolve your problems. If you require legal advice, you can consult your own lawyer or legal advisor. But I will try to answer general questions at the end on how things work, etc. So I know that everybody wants to answer, usually asks questions about themselves, but try to make it a bit generic, okay? So we got to know where we came from to know what the changes are, right? So I'll talk about a little bit about the legislative history of placement from hospital to long-term care. So the Long-Term Care Homes Act, which was the previous legislation, came into effect on July the 1st, 2010, and it replaced 3 pieces of legislation and a big program manual. So anybody who was back that long, and I know there's a few people out there who are, will remember those days. So the Long-Term Care Homes Act was a really comprehensive piece of legislation and regulations that sort of encompass these 3 pieces of legislation and the program manual into one place. And it was really an overhaul of the entire long-term care system in Ontario to try to make it more resident focused, to make it very clear as to how everything was work and what the expectations are. And certainly, it certainly is probably one of the more comprehensive pieces of legislation in the world, probably. I think probably as Shelley was mentioning about the new standards that came out last week, and Minister Calandra commented that, he didn't want to water down his legislation. I think one of the things that people need to understand is that those certainly are not meant to water down. They're certainly meant to complement. I think it complements Ontario. The biggest problem then probably in Ontario that we have is when it comes to long-term care legislation, has to do with the enforcement of that legislation. So we have pretty good legislation, but it's how it's interpreted. What we're going to be talking about today, maybe not such good legislation, but in general, the Long-Term Care Homes Act and its successor are fairly resident focused. So under the Long-Term Care Homes Act, hospitals, patients would generally be placed into either a Category 3A if they were applying and designated themselves as a religious, ethnic, or that should say linguistic, sorry about that, facility, or a 4A for any other home, or if you were applying to one of those special homes, but you weren't of that designation, you would go into a 4A category. And that was generally what would happen. A hospital patient could be put in a crisis category, even from hospital. There was a designation. So if you required immediate admission to a long-term care home because of a crisis due to your condition or circumstances, if your bed was being shut down in a hospital, and we did certainly have seen hospital closures in the past, or where there was a hospital in crisis, which required that the patient had to be an ALC patient requiring immediate admission. Hospitals experiencing severe capacity pressures, the designating agency, which has been different things at different times, but it had to, in consultation with the hospital and placement coordinator, would verify that there were these conditions out there. They had to do it in writing, and they would have to set out a period of time during which the process would could occur. So it was a time limited. I definitely have had clients who have been crisis from hospital, prior to this legislation, where it had to do with their personal circumstances. So it's not something that was used a lot. Hospitals really wanted it because, of course, they wanted the turnover in their beds, but it wasn't something that we saw a lot. So placement into long-term care from hospital prior to COVID-19. You could also qualify for other categories. So common categories were readmission categories. And that had to do with if you were in a hospital from a long-term care home originally and you lost your bed because you exceeded the allowable number of days, you go back into like basically the highest category to be sort of admitted in the next bed that's sort of available and appropriate. There's also the reunification priority access beds, which we'll see a little bit about. And that's where the patients in crisis themselves, and they have a spouse or partner who is already in the long-term care home, and so that they can go and be reunified with them. But they have to be in crisis themselves, and that person has to already be living in a long-term care home. Each long-term care home can have 2 persons in them with who are designated as RPABs. So it's not like a specific bed in the home. It's just one of, it's just, it's a sort of a virtual bed, shall we say. So the effect of COVID-19 on admission. So what affected the pandemic have on the admission? So it certainly did have an effect very early on. So right at the beginning of the pandemic in March of 2020, changes were made to the admission criteria, the admission rules around admission to long-term care. And among those were changing the waiting list category for all hospital patients who are waiting for long-term care, which they call alternative level care to long-term care, or ALC to LTC patients. They were all made a crisis category, unless you could qualify for a higher category bed, such as an RPAB bed or a readmission category. So they already started to change some of the rules, and people in hospital who were requiring long-term care and no longer required the hospital would be going into that crisis category, and so they could be moved out of hospital quicker. So then we come to December 2021, and legislation was passed called the Fixing Long-Term Care Act 2021. It came into effect on April 11th of 2022. There were some changes in that legislation that were made, including changes to targets for hours of care, for example, changes around compliance and enforcement, including the use of administrative monetary penalties in the legislation in a different fashion that they had been legislated previously but never used. However, if you really looked at the act and the regulations, most of what was in there was pretty identical to the previous act and its regulations. So there were definitely changes, but for the most part, things were pretty much the same. It included these new categories, so admission from hospital under special circumstances. So it continued to require ALC patients to be put into the crisis category or higher due to the pressures of the pandemic. But when this legislation initially came out in April of 2022, it had a time limit on that crisis category. So it was only going to exist until October the 11th of 2022, at which time the special designation of all ALC patients as crisis was going to be removed, and it would revert back to the same normal requirements which had been previously outlined in the Long-Term Care Homes Act and now in the Fixing Long-Term Care Act. That would be normally the person would be either a 3A or a 4A for the homes that they applied to, unless they had some other reason to go into a higher category. So that's where we were until August the 18th of 2022. And at that time, the More Beds, Better Care Act was introduced by Minister Paul Calandra, so it's the Minister of Long-Term Care. This was entirely unexpected for most of the sector. And in our opinion, it doesn't provide for either more beds or better care in the long-term care sector. And so, it was a bit of a misnomer, as in my opinion, many of these pieces of legislation are, but it certainly did shake things up. So what the contents of Bill 7 was to allow placement coordinators to choose homes on patients' behalf, make applications to homes, including release of personal health information, accept beds on patients' behalf to homes that they had not chosen. And frankly, it removed the fundamental right of choice and consent in the placement process. If you didn't do what they wanted to do, they could do it anyway. The stated purpose of the bill is to free up hospital beds that were being seen as taken up by undeserving ALC long-term care patients, often referred pejoratively as bed blockers. These patients were often, or their substitutes were often seen as uncooperative and refusing to apply to homes that they did not want for very good reasons, but they were seen as being uncooperative to the system. Of the approximately 6,000 ALC patients that were in hospital at that time, only about a third, so about 35%, were ALC to long-term care, and the rest were really ALC to other destinations. So ALC does not mean you're waiting to go to long-term care. It just means that you no longer need the bed that you're in, whether it be an acute care bed or maybe you're in a rehab bed, whatever. It means that you don't need that level of care. You need to go somewhere else. So you can be waiting for another kind of a hospital bed, such as a rehab, a chronic care, or psychiatric facility. You could be waiting to go to a retirement home. You could be waiting for maybe some upgrades in your home. Maybe you need a ramp put in and you can't go home until that happens. There's lots of things, destinations for ALC patients. So this bill focused specifically on those who were ALC to long-term care. So no public hearings or consultations were held for this. The bill was passed into law and received royal assent on August 31st, which was less than 2 weeks from the start to finish, with only 5 days of debate in the legislature. Which, if any of you have been involved in any kind of legislation, really, that is very, very fast. It's very rare that you see something like that, except in in a state of emergency, like we saw maybe at the beginning of the pandemic. But this was something that was extremely out of the ordinary. Minister Calandra indicated that regulations would be released the following week, and you can't go forward with the legislation without the regulations. So the legislation's the framework, and the regulations are sort of the meat and potatoes and the instructions on how to go. So you need that regulatory framework. So we knew that they were doing away with consent, but in certain situations, but we didn't know how or when or what have you. So that didn't happen the next week. The House rose for a 5-week break on September 14th at 2:47 p.m., which means that there were not going to be any debates in the House for 5 weeks. And at 3 o'clock, Minister Calandra and Sylvia Jones, who's the Minister of Health, held a press conference announcing the substance of the regulations and released some supporting materials to support the new regulations. The regulations were released the following day, and with the bulk of them to take effect on September 21st, 2022. There were also regulatory amendments to the Public Hospitals Act, which also include the threat of discharging for refusing to go home to a home not of your choice, and a mandatory $400 fee if patients remained in hospital after discharge. And those were didn't take place until November of 2022. So what happened? So we have ALC patients that are not exactly defined, but are kind of defined in the legislation. I wouldn't say that they're really defined still anywhere properly. But the section applied to ALC patients who are persons who occupying a bed in a hospital under the Public Hospitals Act, and who have been designated by the attending clinician as requiring an alternate level of care because, in their opinion, they do not require the intensity of resources or services provided in the hospital setting. So it doesn't mean they don't require any care, it's just not that level of care anymore. So in general, Section 60.1 was added to the Fixing Long-Term Care Act. It gave attending clinicians more authority, allowed certain actions to be performed without consent of the person or their substitute, and it had some requirements of the licensees, so the people who are running the long-term care homes. It did identify who the attending clinicians were. So It's generally attending physicians or nurse practitioners. It could be a midwife, certain kinds of dentists, dental surgeons in hospital, but for the purpose of long-term care, we're really looking at either an attending physician or an attending nurse practitioner who is going to be involved with this. They can now request that a placement coordinator determine eligibility, select a home, provide assessments to the home, and authorize admission to the home. And that was something they wouldn't have been able to do. They would have had to have consent to go through that process. And now that's not required anymore. Do even do those requests. It also allowed a physician, registered nurse, social worker, or anyone else designated under the regulations to do assessments of ALC patients to determine their eligibility for admission to a long-term care home. So that has been added as well. So the legislation also included the fact that placement coordinators could now do certain things. So they were now allowed to determine eligibility, which of course they've always been able to do. But they're allowed to select homes, provide assessments to the home, authorize admission to the home, and transfer responsibility to another placement coordinator. Now, they've sort of always been able to do that, but now they can do it without consent. So these actions previously couldn't, you required consent from either the person or their substitute decision maker at all the different levels. So, you couldn't send information without consent. Homes couldn't be chosen without consent. Even if, residents or applicants could certainly say, I don't know what to choose, you can help me. And so they could do that. But again, at the end of the day, if the placement coordinator said, I'm picking, I think Happy Valley, we should put it on the list. The person would still have to consent to that. And this has now been changed. So what they have to do is they have to make a reasonable effort at all the steps to obtain consent from the patient or their substitute decision maker. And remember, this is only in the ALC, so only in the hospital setting. This does not apply in any other setting, but they have to get consent, try at least to get consent from the patient or their substitute decision maker if they're not mentally capable. However, what's new is if they don't consent, they can go ahead and do these things. And then the requirements set out in the Act in section 49 to 54 don't apply. And those include the sections around consent. So those sections have been carved out. They don't have to comply with some of the rules when they're going without consent. If at any time during the process, the patient or their substitute decision maker change their mind. So let's say maybe that they've started the process doing assessments, and when it comes to choosing the homes, the person says, well, okay, I'm going to choose the homes now. If they consent at any time, then the requirements of section 49 to 54, including, informed consent, will then apply. And interesting, although the Act is supposed to uphold the residents' rights in the Residents' Bill of Rights in the legislation, what the legislation says is that it actually doesn't contravene the Residents' Bill of Rights. And it's kind of hard to understand how failure to uphold consent rules and informed consent and allow choice can be done in conjunction with the Residents' Bill of Rights and support that. But that's what the legislation has said. So it now says that this does not contravene Residents' Bill of Rights. What it tells licensees is that they must process and approve the application that has been provided to them, and that they can only reject if a condition under section 51(7) is met. And those conditions are that the home does not have the nursing expertise that is required, or that the home does not have the physical facilities to meet the needs of the applicant. And those conditions are the same whether it's a consent application or not, but it makes it clear that those are still the only reason that they can refuse. And it says that they must admit the ALC patient if they are determined eligible, a bed becomes available, and it's authorized by the placement coordinator. So that's the legislative sort of framework. So then we have the regulatory changes under the Act. So there were actually 3 sets of regulations. One was under the Fixing Long-Term Care Act and 2 are under the Public Hospitals Act. So I've separated those out a bit. So under what the regulations under the Long-Term Care Act, Fixing Long-Term Care Act, I mean, it's fairly lengthy, and I've definitely minimize what I'm going to talk about today, because a lot of it is very detailed that's not necessarily required sort of to understand how you might go through the process. So there's been change to the RPAB bed designations. So previously, once someone went into one of those RPAB beds, which is for the people who are crisis and are joining a spouse in long-term care, once they were in one of those beds, they retained that bed. Even if their spouse moved or died, they would still be in the RPAB bed. And that didn't actually make a lot of sense, I don't think, from the beginning, in my opinion. But what this new legislation says is that if the spouse is no longer there, or dies, or goes to another home, or ends up in hospital and isn't coming back, then that person is no longer designated as using the RPAB bed, and it would be available to someone else to come in. Sections 240.1 to 240.4 are the new regulations setting out all the powers of the placement coordinator and the exemptions to the normal placement process. That section that I talked about before that said that the ALC crisis designation was going to be removed on October 11th, of course, that was removed. And it revoked the definition of personal health information, interestingly. And that's to do with the fact that they're going to be providing, I think, personal information to homes without consent of the person or their substitute decision maker. The changes to the Public Hospitals Act, there were 2 pieces, and one was the designation of patients as ALC by their attending physician, or sorry, attending clinician. And the other was the mandatory $400 a day fee for discharge patients. So if you were offered a bed and refused, that's when, that $400 a day. And prior to that, it wasn't that they didn't charge for those things, they did. But many of you may remember when this bill was being debated and was in the media, people were talking about numbers like $1,600 a day, and the minister kept saying, no, it's not. It's, that's certainly nowhere near that. It absolutely was, because there was no amount that the hospital was allowed to charge, because what they're doing is they're saying you can stay in the hospital, but we're not covering you with OHIP anymore. So you have to pay sort of the full freight. And so prior to this legislation, there was no maximum, but it also wasn't mandatory. And that's the 2 changes. So they've made it mandatory to charge, and have set the rate that they must charge in these cases. So what's the process? So the placement coordinator has to try to go through the regular process. So they can't just jump right to, doing it all without consent. They have to explain the consequences of what will happen if you don't consent, that the placement coordinator will proceed without obtaining the consent of the person or their substitute decision maker, that the application can be started and processed without consent, including the choice of homes, that your personal health information or that of your loved one will be released to the homes by the placement coordinators without consent. It can be done, that can be done. And that the placement coordinator can actually accept a bed offer on behalf of the patient or the substitute. So they're going to accept the bed offer and say, yes, we're accepting it. And so you can go right from, you could have never actually put an application, and you could end up with an accepted bed offer and a bed being available for you in a long-term care home, and have never consented to the process. When it comes to choosing the homes, the placement coordinator has to consider certain things. So they have to consider the patient's conditions and circumstances, the class of accommodation requested by the patient, so semi-private, private, or basic. And if they don't request a class, then they apply to basic. They have also included in the regulations how close it has to be to the home. So the proximity is 70 kilometers from the patient's preferred location. 150 kilometers if they are in the northeast or northwest Lynn, and yes, they still use Lynn in this context, unless there's limited or no vacancies at the time, and if that's the case, they just go to the closest home. So it can be 150, it could be 200 kilometers. The north is vast, and you could end up very far away from where you want to be. It certainly gives you the it defines what the preferred location is. So usually it's somewhere that's identified by the patient, or their substitute. So if you say you lived in Toronto and you want to be in a home in Toronto, then you would say let's say from your house, right? You could say 70 kilometers from where I live. But let's just say you're living in Toronto, but your daughter lives in Ottawa. So you might say, my preferred location is my daughter's house in Ottawa, because that's where you want to live. So it would be 70 kilometers from there. Otherwise, if you don't identify one, it would be your residence. And if you don't have a residence or none is identified, then it would be the proximity would be from the hospital. So ALC patients will be put into the category 1, which is the crisis category, unless they meet criteria for a higher category. And while individuals with the highest need are still going to be prioritized regardless of location, in general, preference is going to be given to hospital ALC patients. So, there definitely is sort of become a 2-tiered list in the placement process. So, if you're in the community and your house burns down or your caregiver dies, you could get into that, you could be prioritized above someone from ALC. But in general, what we have been told and what we have seen is that it's really only ALC patients that are being placed into long-term care on the crisis list right now, because of course we have so few beds are available for a variety of reasons, and they're being filled with hospital patients. So what they cannot do is they cannot physically transfer you without your consent or that of your substitute decision maker. So the placement coordinator can say, I've accepted Shady Acres on your behalf. And then they can come to your room and they say, okay, we're moving you now, and we're going to take you and going to transfer you over to Shady Acres. And you can say, no, I do not consent. So they cannot physically take you, put you in a car, move you down the hall, move you to the home. So they cannot do that without either your consent or that of your substitute decision maker. So what they'll have to tell you is if you refuse, they could you can be discharged from the hospital. So they could say, okay, well, we don't think you need to be here, and we think you can be at home, so we're going to discharge you from the hospital and say goodbye. If you remain in hospital, because really you can't go home or into the community, you will be charged $400 a day. Whether or not the hospital can collect the $400, whether or not they can actually, whether they actually will try to collect the $400 per day is a different question. They will bill it. Many people do not have the money to pay that, and will never have the money to pay that. So, that they can certainly, charge anything they want. But if you're on a fixed income and on old age security and guaranteed income supplement, they're non-garnishable. You could get sued, they could win, they still can't collect. It is not a collection from your family. The only person that can be charged is the patient. And I think there's questions about that if they're not capable around substitutes refusing and then the patient being charged. So, I mean, those things, it's all early days now. We haven't seen too many charges in the $400 because most people are going to long-term care. But that's what will happen. The placement coordinator can authorize the ALC patient to be admitted to a preferred accommodation bed, even if they request basic. So Shady Acres only has private rooms. You've asked for basic. You could be put into that facility in the preferred accommodation. You will be charged the basic rate with any rate reduction you'd be entitled to. You will be placed on an internal waiting list to transfer to basic accommodation. If a basic accommodation bed is offered to you and you refuse it, so you say, no, I like this private room, then they're going to charge you the preferred rate. So if you go into a private room and you like it and you want to stay there, once a bed comes up in that home, if you don't accept it, they will charge you the full rate. If you're going to transfer to another home, so if the facility, the long-term care home was one that was chosen by the placement coordinator. So you didn't choose the home, you didn't consent, but you acquiesced to going there. So you didn't refuse to go there. You did say, once a bed was offered and they said, okay, the bed's there, it's been offered to you, I've accepted the bed. You either go there or we're going to charge you the $400, and you say, okay, well, I'll go there. If you haven't chosen any other homes, you have 6 months to do so, and you will be placed on the crisis list for all of those homes. If you are offered a bed in a preferred home, so let's say you go to Shady Acres, which is the home you didn't want, you never applied to, and a bed in one of the homes that you did actually apply to comes up. If you refuse, then you're going to be taken off of all of your waiting lists. So you have to be very careful in sort of what you're doing. So what are the issues here? What can we talk about? What sort of issues sort of arise here? So information that has to be provided to you. So the whoever's providing the information, whether it be a hospital person or the placement coordinator, they have to explain why a long-term care home might be more suitable to your needs, to both personal and medical needs in a hospital. And they have to tell you that a hospital is no longer an option for you to wait for further services, including the need that they have to provide care for more acute and emergent patients. So they're going to tell you, you don't need to be here, and somebody better is more deserving of that bed. And that's some of the information they're going to provide to you. And it's certainly true that there are pros and cons about why people shouldn't stay in hospital for long periods of time. They don't offer certain things. And that's certainly information that without this legislation, we have always suggested that people be provided with in order to make an informed decision. They are also to explain that all long-term care homes are required to meet the same standards of care, regardless of home type, ownership model, location, size, etc. We know that that is a requirement. We also know that that's not reality. And, every home is not the same, and they don't meet all the same standards of care, even though they're supposed to. We know that isn't true. They have to explain that long-term care homes provide a home-like environment and can offer more recreational services and social supports. And I think, again, some homes are more home-like than others. Some are very institutional and some are very home-like. And I think, and some offer lots of recreation and social, and some don't offer that much. But I think there's a huge difference in the homes, and that's why people choose different homes. And again, they talk about some long-term care homes being better to meet culturally appropriate, religious and linguistic services. Now, the interesting thing I think about that is that while that is true, those are generally the homes that are the hardest to get into. And so they're telling you, oh, this is something that, you should be considering. And yet I can tell you that when you're going into that placement process, it's very unlikely that one of these homes are going to be the ones that they're trying to push for their agenda to get you out of the hospital, because they're going to have really long waiting lists of crisis, regular, and everything else. So the big question is, should you consent? So there's going to be a lot of pressure, and this is the calls that we're getting. There's going to be a lot of pressure put on you to consent to the application to the home that you don't want throughout the process. So they're going to say, we're going to put the application in, we're going to choose homes for you, blah, blah, blah. You're going to be told that, the process is going to go ahead anyway, so without your consent, so you might as well do it. We do not recommend that you consent at any point in time until transfer. So if they want to do the application, obviously some people are going to already have applied, so they may be already on a waiting list for homes, and that's fine, but do not put homes on a list that you do not want. If they want to put the homes on that list, let them do it. Let the placement coordinator do that, and do not consent to it. If their bed offer comes in and they say, are you going to accept the bed? You can say, I will not accept that bed. I won't refuse a transfer, but I will not accept that bed. And there's a very good reason for that. So obviously, if you want to stay in the hospital and pay the $400, you can obviously do that. But for most people, that isn't the option that most people are going to choose. Most people are going to say, I don't want to have the $400 a day. I don't want to get into that hassle. However, if you are placed through the consent of the placement coordinator, you will remain in category 1 on the crisis list for all the homes you've chosen. You retain your some chance to move to one of your preferred homes. If you've consented to like the homes prior to that, and regularize the application. So anything to do with the application to the home. Once you're admitted to that home that you put on your list because you did reluctantly consent, you will not be category 1 crisis for any of your preferred homes. You're going to be a category 3A or 4B for your first home and a 3B, 4B for your others. And it's unlike you will ever move to any of your preferred homes. So if you have homes you want to do, you can certainly participate in that part of the process, but do not put a home on that they want you to put on that you don't want. They want to go through that, they can. And if they can accept that offer, and if they accept that offer for you, if you go, you will be on that crisis list. But if you sort of acquiesce and say, okay, we'll put it on my list, I'll sign the form, which is what they want you to do, you will not be a crisis for any of your homes once you get there, and you will not move. Very unlikely. One of the other things that people have to understand, and which I think is a really terrible outcome here, is that the costs associated with moving to a long-term care home, they've always generally been borne by the person anyway, but the ministry's indicated that they are not funding transportation, even if it's to a home that you haven't chosen. And depending on where that home is, it could cost hundreds and thousands or thousands of dollars if you require transportation service, so like an ambutrans or an ambulance service, to move you there. So if you are, say, living in downtown Toronto and you're in a hospital in downtown Toronto, but they're moving you to, a small town, say they're moving you to Port Perry or something that's, I'm sure, within that distance, you would have to pay because you can't go by public transport. You don't have anybody to transport you, or you require a transportation service. The cost to get there is probably going to be high hundreds or thousands of dollars to move you. And there's no funding for this. And I think that's very unfair to require people to not only go to a place that they don't want to go to, but also to bear the cost for that. And there's also no funding to visit that person. So what about the spouses living in downtown Toronto who now has to, even if they go by public transportation, they might have to get a bus and then a subway, get on the GO train, get out to Whitby, then get on a bus to go up to Port Perry, and then it's probably have to walk somewhere or take a taxi to get to the long-term care home there. The cost, the stress, and frankly, if they're a frail elderly person themselves and it's in the winter and it's snowy and icy, their ability to get there safely is, can be, quite significantly reduced because of ice and falls and all of that. And the cost is going to be very high. And so they may not even go. And so now the person has no one able to visit, if they don't have anybody who can drive them up, and, many people don't have that. So the effect on people is going to be very negative, and we've certainly seen that. Frankly, the likelihood of transfer, though, once you're put into one of these homes, even if you remain on that crisis list, so you went into the home and had never consented to the bed, but did acquiesce to the transfer, again, probably unlikely to ever move, because you're going to continue to be bumped by the transfers from people from hospitals. So those ALC patients are still coming through the process, and they are still likely to bump you in the preferences. So one of the issues that we've always had is people in hospital applying for long-term care, and anybody who's sort of been around for a while knows that we've, have always stood up for the rights of the patients in hospitals, and, hospitals have consistently since, the entire time I've worked here, have tried to make their own policies and their own rules around applying for long-term care. And that hasn't changed. And, I surprisingly, they're still doing the exact same things as happened in the past. So although there is an expanded role for the clinicians in the application and assessment process, the clinicians in the hospitals do not have the authority to prevent you from applying for admission to a long-term care home from hospital. So you have every right to do that. Require that you move to the community to apply to long-term care. I'm hearing that a lot still, where people are being told they have to go home or to a retirement home or something in order to apply for long-term care. That's not true. You don't require the hospital's permission to apply to a long-term care home. And hospitals do not determine whether you will be on the crisis list. And I still am hearing this a lot, where people are being told by the hospital, well, we'll decide if you're going to be crisis. No, anybody who's applying, who is in a hospital and is waiting for long-term care is on the crisis list or something higher. The effect on admission from the community by Bill 7, and frankly on some of the other pieces of legislation that we've seen since the pandemic, where people were being put in the crisis category, is that this preference is still being made for hospital patients. So unless it's a very critical need, people who are crisis in the community still continue to be bumped by LC patients. And the consequence is that hospitals are really becoming the conduit to long-term care. So instead of keeping people out of the hospital, they're actually funneling them to the hospital, because if you require long-term care, you are very unlikely to get placed in the community. It's all from the community, sorry. And the people in the community are at risk because they're probably not being able to get enough home care, because that is not, we haven't bumped up the home care to prevent people from going, which is really what we really need to be doing. We need to be preventing people from, getting to that crisis stage, assisting people in the home, preventing caregiver burnout, allowing people to stay at home as long as possible, and hopefully forever. But the government, continually does the downstream stuff. So they just only do it where that crisis point is. And it's usually where it's a crisis in hospital. So, unfortunately, we're not seeing, a lot of changes there. And so really what's happening is that people have to go in hospital. So they're breaking, they can't be kept at home. Something happens, they break their hip, their caregiver gets sick themselves. And now you end up with 2 people in the hospital, and hospitals become the conduit to long-term care. The substitute decision makers are being put into a very difficult position, because they're being asked by placement coordinators to choose homes that may not be in compliance with their legal requirements for decision making under the Healthcare Consent Act. So substitute decision makers can't just choose any home they want. They have to either comply with a known wish, or if none, they have to act in the best interest of the incapable person. And that's actually set out in the Healthcare Consent Act, and nothing changes that. So they're going to be asked, well, you have to go to Shady Acres because it has a bed open. And they may be able to articulate, well, mom said she never wanted to go to Shady Acres. And they say, well, too bad, we're going to apply there anyway. Or they may say that is not in her best interest and have some very good reasons, like it's taking her away from family, friends, maybe too far, may not provide the right kind of care. And they're being told that, if they don't comply, they're going to override them. And that's a really big issue. There is also an issue around sort of what we call difficult ALC patients or substitute decision makers. So there's certainly been an emphasis, I think, on difficult people who may only pick one home. And, while this may occur, it's a minority of cases. Most people, if, things are discussed properly, they generally have, do make numerous choices. If the placement coordinator, works with them, etc. In the past, there was a way of challenging substitutes. It actually still continues now, but there's always been a way of challenging a substitute decision maker who may be not making an appropriate decision. They may say, oh, I'm just going to pick this one home. And they've always been able to be brought to the consent capacity board to challenge that. However, there's never been a reported case related to home choice. So, you know, we hear a lot about in the past about the LHIN saying, well, you know, this SDM only picked one place and it's not appropriate. Well, then they should have brought people to the consent capacity board, and they've never done that. I wanted to talk just a second about transitional care. So some hospitals have transitional care units, and it's very important if transitional care is being offered that you find out what it is. So there are some transitional care units, which may be in a hospital or maybe in another space. It could be like in a retirement home, for example, but that may be a designated hospital space. So if you're talking about transitional care, you need to find out if those beds continue to be hospital beds. If they are, the special rules apply, including being on a crisis list. If you are applying for, you know, you're always usually waiting to go to long-term care. And also the placing without consent is also still part of the process. However, there are also transitional care facilities that receive government funding via hospitals and other organizations, which are not designated as hospital space. So in those places, there is no automatic placement on the crisis list, but they can't go the no consent route. So, you know, whether one is better than the other, you have to look at what the services are, what are you being offered, you know, which is it appropriate for you? Now, if they're moving you to a transitional care unit, that's a hospital unit, you don't have to consent to that move. They can move you, but you do retain that crisis list. But on the other side, you know, no consent can be pushed on you. So just if they're coming to you with transitional care, find out what it is so that you can make appropriate decisions. Hard to place applicants are still going to continue. These are people usually that have maybe some special kinds of equipment requirements, have behavioral issues. And so we often see them as eligible, but not placeable, because homes will continue to refuse them even though they're eligible. You know, I've had people on eligible and not placeable for 6 years. I have one person who said to me today, "Oh, make sure that you tell them that I've been waiting for 6 years as a crisis." And they can't be, and they're not moved because no one will accept their application. The ministry did announce some assistance for people, such as equipment like bariatric equipment, some support services. But in my opinion, the homes will continue to reject. Historically, there's been many homes who refused applicants, even though they're not legally allowed to do it under the legislation. So they use reasoning that they're not supposed to use. And we believe this will continue. And what happens in these cases is that the homes with available beds, which are often homes with poor records, will accept the people who probably they are least likely to be able to provide care to. And so these hard to place applicants will still have issues with both their placement, because they may actually end up being pushed into homes with that really can't meet their needs because of the new system. And finally, I think that what I can say is that those who advocate will likely have a better outcome, and those who know what their rights are. Those who don't advocate or don't have support are kind of probably end up in places that have more serious compliance issues, because those are where the beds are going to be. And so if it's you or your loved one, definitely advocate and push back, and hopefully you'll be able to see some movement, or be able to get homes that are more suitable for the person. So that's it. So I am ready for questions.
Jane, that was an incredible overview of the bill, and you gave lots of strategies there and the history behind it. So thank you so much. A number of questions have come in, so I'm going to ask them. I know technically, I think we'll go to 8:15. I'm just going to take that position. I'm going to ask the questions. Jane, can you tell us a bit what you're seeing on the ground? Is Bill 7 being used as a threat, or is this actually going on in the hospitals? Are people being charged? What do we know of what's going on the ground?
So I would say that what we're seeing for the most part is that people are acquiescing, so that people are being told, well, it's going to happen anyway, and so that they are consenting to those applications. I'd say that for the most part, unless, they call us sort of earlier on in the process rather than later, that's what we're hearing. And that affects their placement, whether they're going to be in a crisis list. So if they call us, we'll tell them, don't accept those beds. Like, don't consent to those beds. If it comes up, you may want to move, but don't accept them and put them on the list. But I think that for the most part, we're seeing we're hearing that most people are acquiescing. I've seen a couple of people who are been charged the $400, but that's sort of few and far between.
So we haven't heard a lot about the imposition of the $400 a day.
No, because I think most people are just really afraid.
Is anybody collecting statistics? Are hospitals being mandated to collect statistics?
Ma'am, they don't want to know.
Don't want to know. There was another concern expressed that this is going to wind up putting people into a situation of homelessness. Are you finding that?
I don't know that this legislation particularly does that, although one of the interesting things in the when you look at the Public Hospitals Act regulations, it does talk a little bit about if the attending clinician believes that you should be somewhere else, and it doesn't necessarily identify what that should be, that they could do that discharge in the $400. So it appears that it's actually a bit broader than just those ALC patients that they can throw out. So there would be situations. I don't know that this particularly changes what we've seen in the past. And there's always been a vulnerable population where they are being discharged to homeless shelters, to the street, when they really should be going to long-term care. And, I've dealt with a number of those cases over the years. And it's, those are obviously just a really small sector at the top, because those are usually the most vulnerable people who, wouldn't necessarily be able to access resources like our office. They just wouldn't, they don't have advocates, they don't know, and they just get pushed back. But, it's certainly not tied to this legislation. The legislation doesn't help, but it certainly has existed in the past and continues to occur.
Wow. Okay. I know that ACE and Ontario Health Coalition have talked about an application to challenge whether or not this bill is constitutional. Just wondering where that is at. I know you can't disclose anything that's confidential, but in general, maybe you can just let us know where that is at.
What I can say is it's moving forward, and expect it to be, the application to be put in as soon as possible. It's these are very lengthy and they're very complex applications. So it's still on the move. How's that?
Okay.
No, we haven't given up.
Okay, very good. Do you believe, you mentioned that the long-term care population was 1/3 of the ALC population. Is this really going to free up beds? Are we seeing that suddenly hundreds of beds are being freed up?
I don't know that the numbers are changing all that much. It's hard to say. I see different numbers all the time. I certainly know that I believe that there was sort of initially a fair number of people that moved out from hospital into long-term care. And that doesn't necessarily mean that they were moved to homes that they didn't want. That would include anybody going to, include people going to the homes that they wanted as well from the hospital. Because it coincided with some changes to the bed allocations in long-term care. So during COVID, the homes had to set aside a certain number of beds for infection, for isolation. And they also were getting funded if they weren't full. And that changed. So all of a sudden they had to put all of those beds that were isolation beds back online, and they had to be full sort of all at the same time. So the numbers, people did move out, but I think they've probably just been filled up anyway, because we're seeing, as I said, people can't get into long-term care. So inevitably something happens and they end up in hospital and are now waiting. So, but it's very difficult. I've seen different statistics, but I don't think it's changed much.
Okay. We have a question. If someone has moved to a long-term care home where they don't want to go, I think you've dealt with this, but you can maybe answer it again. Will they remain on the wait lists of the other homes of their choice?
They will remain on the wait list of the other homes on their choice, unless they turn down a home. So if you are waiting, and say you chose 5 other homes, and they offer you a bed in that 5th home and you turn it down, you're going to be off all of your lists. That's going to be the end of it. The difference is that if you actually accepted to put that home on your waiting list, the home you didn't want, if you actually put it on your list and consented to it, even though it was under duress, you will be on the lower waitlist category of 3A or 4A for your first choice home, and a 3B or 4B for the rest of your home. So you're really only waiting for the top home, and you're probably not going to go to that. So you're unlikely to move. If you never consented to going into that home, that the placement coordinator wanted you to choose, so they chose it, they accepted it, but you did not refuse the transfer, so you did go, but you didn't consent to the bed, you remain in the crisis category for all of the homes you chose.
So what I'm hearing very strongly as a strategy, and I guess we have a wayfinding program which assists people who have some questions, is don't ever consent to the particular home. Because that means that you will not be on a crisis list for the homes that you have otherwise chosen. Is that correct?
That's yes. And that's there's something called the field guide it's confirmed in that was something that sort of came up, and it was one of those sort of sneaky things that we sort of didn't initially realize till we really reviewed the legislation and the field guide and realized that this was an unfair thing, that people are being coerced into choosing, and then they're being penalized for sort of going along with the process. It's very unfair.
Yeah. So I guess you have to be really careful what you do. There's various forms, I'm sure, that are being presented to people. Really careful about what you sign and what you put in those forms.
Yeah.
And it sounds also like you really need an advocate through all of this.
Absolutely.
That you don't want to be alone in this. Somebody had asked the question, when there's a priority for spouse reunification, does that include same-sex spouses?
Absolutely. Spouse is, and it's a spouse or partner. So a spouse, partners used to sort of be the key, sort of the key to the same-sex partner sort of thing, but that's gone by the wayside a long time ago. So a spouse is a spouse, whether it's same sex, common law, what have you, doesn't matter as long as it's a spouse. A partner is a person that you've lived with, and that you're the most right prior to, and that you're the primary importance to each other, sort of thing. And so we've used that in cases, for example, when it comes to placement, that will get used, for example, with, say, like an elderly mother who's been taking care of her son who has Down syndrome, and she's turned 80 and she needs to go to long-term care. He can't be, there's no siblings, no one to take care of him. And he now needs to go to long-term care as well. And he would be her partner because they live together and they're of primary importance to each other. And so it could be, mother-daughter, the daughter's been taking care of mom, and maybe the daughter gets sick. And that's, we see that happen too, right? Where the daughter maybe has a stroke at 60 and has been taking care of the 80-year-old mom. And so she goes in, and then mom would be the partner to go in. So it gets used that way. Okay.
And you've mentioned a number of strategies to deal with Bill 7. Is there anything you haven't mentioned that you'd like to profile to people if they've got a loved one who's in hospital?
I don't think so. There was one thing that I didn't put in that I meant to, or I thought about, and it's just really a clarification, nothing to do with the process, but I think that people get confused between the $400 and the chronic care, the ALC copayment. So if you are waiting in hospital and you meet all the criteria, they can charge you the chronic care copayment, which is approximately equivalent. It's the maximum is equivalent to basic accommodation in long-term care. The calculation of rate reductions is different. So if it's based on, in hospital, when you go for a rate reduction, it's based on taxable income only. And so if you're on guaranteed income supplement, that is excluded from it, because GIS is untaxable. If you were in long-term care, it would be included, and you only get to keep your 149, but in hospital, you actually get to keep your GIS plus the 149. And it's also much more, in hospital, it's also much more generous when it comes to dependents than long-term care homes are. So that's just to know that, because I think a lot of people come and they say, I thought we didn't have to pay anything unless we said no. And they get, are told, oh, you're supposed to pay $1,600 a month, and they get really confused. So that still stands.
Okay, so there's still the co-payment.
Yeah.
We have a question. Can this move by the government be challenged so that individuals can receive direct funding to get the care they need?
Direct funding has been difficult. There is still direct funding. It's never been utilized very well for seniors. It's usually more younger people. I suppose that it's something that one can always look at. I don't know that there's any specific process at the moment, but it's certainly something to keep in mind.
Okay, I'm looking at comments. Just people are saying this is very deceptive. This is awful. And then, there's a couple other questions. Is there a set preamble that placement coordinators have to deliver to ensure informed consent?
Well, informed consent is, there's no specific wording. There's, a requirement as to what informed consent means, and it's set out in the Fixing Long-Term Care Act. And so, it's interesting because one of it is not, it's not being coerced. And of course, then what the legislation does is say, but if we coerce you, it's okay too. So that's a bit of a problem, but, there's no set wording because it has to be, it really does have to be, it's very specific to the person, whether it be their knowledge base. The way somebody's going to describe informed consent to me is maybe very different than they're going to do it to my mother, although my mom's pretty knowledgeable because she has to listen to me all the time. But it really going to depend if on who you are and what you're deciding, and all of that. So the consent and the what's going to happen in an informed consent really is going to depend on your very personal situation.
Specific situation.
There's certainly a framework in the legislation that says this is what you have to sort of explain.
Okay.
And the other thing too is that one of the things that people don't know is that so a person, like, if I'm making a decision for myself, whether it's treatment or a placement or whatever, I get to make a decision any way I want, right? But if it's my substitute, they're required by law to make a decision in a certain specified way. And it's up to the person getting consent. So if it was a health practitioner, it would be up to them. But if it's placement, it's the placement coordinator actually has to tell the substitute what the rules of the game are. So that they have to tell them, well, you have to comply with a known wish that your mom had or your dad or whoever. And if they don't have one, then there's a best interest, and there's actually sets out exactly what you have to consider for the best interest, which actually includes what the incapable person wants. Just because someone's incapable doesn't mean that they can't say or give a preference. They may still be able to, express their own wishes. You have to consider that. You don't have to comply, but that's certainly a consideration. So that has to be explained to you. So you can't know what the rules of the game until someone tells you.
Yeah, you have to be explained that. Another question, is ACE involved in speaking, advocating at the March 1st parliamentary meetings regarding seniors? I didn't know there were these, but the question is,
I'm not even sure what that is. So if it's federal, that would probably be going through Graham Webb, our ED, who's away right now. So I can't even ask them, but I will certainly, I've written that down. If somebody puts in the chat and lets me know what that is, that'd be helpful.
That's great. That's great. And any comment on what the associations are saying? What's the Ontario Hospital Association, the Long-Term Care Associations? What's sort of going on out there?
Well, I think that, you know, certainly when this came out and we were doing our research, you know, the association certainly did have problems with this. I don't think they want people coming to their facilities that don't want to live there. And, you know, they're having the same issues as everyone else, and just as bad or worse. You know, they're not able to get staffing and stuff. So it wasn't, I don't know that it was that supported. The hospitals is an interesting one because you get a little bit of everything from everyone. We know that, or we know, but we suspect, let's say, that there were several hospital CEOs who pushed this legislation. I think that there are some CEOs out there who are against it and say, you know, we don't want to do this. But it's been mandated, and that's why they mandated it. But it was certainly some of the hospitals were very pro it. I don't know what the OHA says at the moment, the Ontario Hospitals Association, because they have to listen to their people. I know that they weren't, I believe they were not involved at the outset from this. So it was, you know, just as much a surprise, I think, to them as to everyone else.
And there's an interesting question here, and maybe ACE has done this. Is there specific documentation or information handout that can be provided with to families that are dealing with Bill 7? How to interpret it, what to do? Has there been anything done?
Yeah, so I do have one, and I need to update it a little bit with some newer information, and I'm going to be doing that, and I can certainly provide that to concerned friends when I get that done. Just because there's been a few things like that we've learned or what have you.
That's amazing.
You know, it was if anybody gets our newsletter, and if you don't, you can certainly sign up to get it. But when I wrote the initial critique on the legislation and the regulations, it was when it just came out. And so we had no practical experience, and sort of we're guessing at some certain things. And there's certain things that I need to change on that. So I don't want to send it now because I do plan on changing it sooner than later. So I can certainly do that.
That's great. And somebody's clarified that the Elder Abuse Prevention Ontario, that organization has scheduled a meeting with parliamentary MPs to bring forth concerns regarding seniors. That you might want to reach out to them. That I think that was in light of the question about the March meeting. So
I've written down. Yeah, I'll let Graham know, because he's kind of the guy that does that part of it. Yeah.
Perfect. I'm gonna try to wrap things up here. Jane, it was an absolutely wonderful presentation. We have learned so much, and there's questions I think that people want to keep asking you all night, but you've really helped us out, and I thank you for your wisdom and your strategies and for being there. We look forward to maybe having you back again at a later point on another issue. That would be great. Thank you very much to our attendees this evening. And if you've missed anything, as I've mentioned, Jane has generally agreed to share her PowerPoint. This evening's webinar is being taped, and it will be available, I think, within a few days. So we'll have that to listen to. I'd encourage people, if you're not already a member of Concerned Friends, I invite you to become a member, or to learn more about us, make a donation, or as I say to my granddaughter, or all three of those things. Crystal, if you put our URL into the chat, then people will know where to go for that. And I just want to thank everybody for your attention. And Jane, if there's anything else you think we should be doing around this legislation, please let us know. Maybe I'll let you wrap it up. What can individuals and organizations do best?
So if you do have people that are running into issues, certainly refer them to our office. You know, we're interested in the stories. As I said before, the government is not, in my understanding, collecting info because I don't think they want to know the data. In a lot of ways, like if the data works for them, they'll collect it. But if it's, you know, how many people are being charged $400, I don't think they want to know. So please, you know, refer anybody to us that may be able to help us with what we're doing, or we can help them. That'd be great. You know, just make your MPPs aware and the minister aware that you're not happy with what's going on. I guess that's sort of where you need to be. It's really a political, this has been a political issue. It's really not about what's in the best interest of the applicants. It's political, and unfortunately, it always seems, and we saw that we saw it all through COVID. Every time there's a problem in the system, it's the seniors that they go after. This all started to get people out of the hospital because we had to get them out of the hospital because we're going to have this influx into the hospital at the beginning of COVID. And what happened to all those people who were forced into long-term care that they didn't want to go into, homes they didn't want to go to? It was a disaster. So, and I just say I wish this was in person, because I see all sorts of names of people that I haven't seen in ages. And hopefully maybe someday shortly we'll be able to do some of this in person.
That's actually a good incentive, and we hope to do a few more webinars, and maybe the same people will come and we can do it in person and we can meet and mingle. So thanks to everybody. Have a great night, and thanks again, Jane, for your time.
Thank you. Bye.
Okay, take care. Bye-bye.